Okay, Prof. I think we will start our session now.
Yeah.
Um,
Yeah. Would you
about,
would you like me to start?
uh, yeah, I will introduce you first, Prof.
Oh, yeah. Sorry. Yeah.
Good evening. Good evening, everyone. Uh, Thank you for joining us in our Australian Indonesian lecture series. This is actually the maybe the third year of our lecture series, or maybe beginning of the fourth, right, Prof?
I think it's the
Beginning of the
beginning.
fourth years.
Yeah. Yeah.
So yeah, beginning of the fourth years. So hopefully, you all will be enjoying our discussion, and also there will be today, not as same as other Australian Indonesia lecture series. Usually we have like a guest discussion, but today we have two lectures. It will be given by Professor Bill Morgan and me, and the session will be covering about the glaucoma surgery and cataract surgery in glaucoma. So I think for the first lecture will be Professor Bill Morgan. Okay, Prof, the time
Yeah.
is yours.
Thank you very much. Thanks, Verna. I'll just try. Hopefully, I can share. Oh, here we go. Got it. And allow. Sorry. And I. Okay. I think you can see that. Hopefully. Thank you. Thank you very
Yeah,
much for
good
introducing me,
see.
Verna. And can hear me okay? I hope. Yeah. So I thought I would talk a little bit about
Yes, Prof.
glaucoma surgery and planning the most appropriate surgery for the long term, because the glaucoma is a chronic disease, obviously, and we want the surgery to work for 5, 10, even more years. And just to place in context, in Indonesia, glaucoma is very common. It's probably at least twice as common as it is in Australia. It's the second commonest cause of blindness after cataract. And the prevalence in those aged over 40 approaches 5%, goes up with age. And in Indonesia in particular, angle closure glaucoma is very common. So it's about half of the cause of glaucoma. But the problem with angle closure glaucoma is that it accounts for about 84% of glaucoma blindness in Indonesia, depending upon the study you read. But it dominates the causes of blindness, basically. Um, so, which leads me to this slide. And often when we talk about glaucoma, at least in the Western literature, it's really all about primary open angle glaucoma. And we forget about angle closure. Now, this is a study, this is quite a well-known study, the Eagle study, published about 8 years ago, looking at the use of lens extraction in angle closure. I won't go through all the graphs, but what you will notice is those dots that go past the red line to the right on the left-hand side of the graph, or to the left on the right-hand side, it's a bit confusing, showed a significant benefit from using clear lens extraction. So it was well known before this study that clear lens extraction helped angle closure, but this helped to formalize some of the knowledge. This is a slide I've put together, and what I've tried to do is summarize the major causes of angle closure in one slide. And it's really generally either pupil block or ciliary block, or a combination of the two. And in fact, most commonly, it's a combination of the two. Now, pupil block you can usually cure or eliminate using iridotomy, YAG laser iridotomy. Now, that does not influence ciliary block. And the top right-hand image in the middle, the black and white, shows you a case of ciliary block, drawn schematically, and there's no peripheral iridectomy. And the lens and the ciliary body are pushed forwards, and they push the iris forwards. And that pushing of the iris forwards also creates flow resistance between the lens and iris. And the reason why the lens and the ciliary body are pushed forwards is because the lens is abutting the ciliary body. And if you look carefully at the ultrasound, the B-scan ultrasound on the UBM rather, on the lower right, you'll see, and I don't think my mouse pointer shows up here, but you'll see how the lens in this patient with ciliary block, the lens equator comes right in to the ciliary body. And so it basically blocks aqueous coming from behind, which then acts to push everything forwards. And you get the classic volcano sign, and sometimes you can even see the ciliary processes, which are abutting the lens equator. And the reason for that is that light is not internally reflected when the lens equator is directly in contact with the ciliary process, and so it can escape through the edge of the cornea and into your gonio lens. Now, the treatment, as you all probably know, is to remove the lens because it's the size of the lens that's really causing trouble in most patients, 95%. So you take out the lens, you put a much thinner, smaller plastic lens, and all of a sudden the lens equator is well away from the ciliary body. The aqueous can flow between the zonules, and also the lens is much thinner, the plastic lens, and it's not having as much contact with the iris, so that pupil block and ciliary block are eliminated or broken in most people with the one operation. So that explains why it's generally more effective than a laser iridotomy, which is not to say that you should do it in every patient with angle closure, but it's certainly something to bear in mind and to use. So here is a study published, a couple of studies actually, looking at the use of trabeculectomy in acute primary angle closure. There's basically not only a high rate of failure, 34%, this group from Singapore, but also a high rate of complications with 30% shallow flat anterior chambers, which are mostly from ciliary block or malignant glaucoma. And then another study from another group, I think from Thailand, showed high failure rates of trabeculectomy. So the big problem with trabeculectomy in angle closure is that if there is any degree of ciliary block, the trabeculectomy will make that much, much worse. And in fact, any drainage surgery will make it much worse. So I'm not going to, I think Werner is going to talk about cataracts, and I'm not going to mention any more about lens extraction, but to just emphasize how important it is for angle closure. I'm briefly going to mention the MIGs only because people seem to ask me a lot about the MIGs. And I'm speaking here from an Indonesian point of view. This study is probably one of the few long-term studies of a MIGs, which was the eye stent, over 5 years. And the dotted line is the pressure reduction with cataract surgery alone. And the solid line is the pressure reduction with the eye stent, sorry, the Hydrus micro, which supposedly is actually more effective than the eye stent. But as you can see, there's actually no significant difference between cataract surgery alone and a Hydrus plus cataract surgery. So this was Hydrus plus cataract surgery compared to cataract surgery alone. So in your cohort of patients, these, what we would call trabecular bypass operations like eye stent or Hydrus, are probably a waste of time, particularly in more severe glaucoma patients. In my own practice, where I have more severe glaucoma patients, I don't perform these types of operations. So this is quite a nice systemic review, a Cochrane review of various MIGs compared to cataract surgery and compared to one another. And only on a few occasions do they seem to, well, not even show significant difference. You'll see that all of them, apart from Hydrus versus cataract surgery, which in this study they seem to think did make a slight difference, was there any benefit? So the MIGs, I think, unless your glaucoma is mild and you're having cataract surgery anyway, I don't think are that useful, particularly in patients with severe glaucoma, and certainly in patients with angle closure. You wouldn't use a MIGS. I'll skip over CyPass because it's no longer available, but it's basically one of the suprachoroidal space shunts. There is a new suprachoroidal space shunt which is about to be marketed, but it's likely to be any more effective than CyPass, which wasn't much more effective than phaco or cataract surgery alone. So let's talk about the main game of glaucoma surgery apart from lens extraction, which are the drainage procedures. So first off, I'm going to talk about the bleb producing procedures, or what I would call channel creation procedures, which bypass the aqueous outflow apparatus. So that you basically, with a trabeculectomy or say with a Zen stent or the pressure flow, you're either cutting a channel or injecting a channel, which bypasses the trabecular meshwork, Schlemm's canal, the collectors, and even the aqueous veins. And you're delivering aqueous humor directly into the subconjunctival space. However, now the top figure is what I would like to see in all of my patients. Nice surgery, nice diffuse bleb. But in quite a few of my patients, I get this sort of middle bleb which is very vascularized and constricted bleb, unfortunately. Or when I'm lucky, I get a nice diffuse bleb, which lasts for a long time, and I can even see lymphatic vessels connecting to the bleb, illustrated by that green structure on the right. So when I do a trabeculectomy, I'm never entirely sure which way a patient is going to go. So we don't know until we do the surgery whether the patient is going to end up with a scarred small bleb or an encysted small bleb or a beautiful bleb which is over a large diffusional area. So how can we tell how the tissue will respond? Well, we can't always tell, unfortunately. And so whenever we do one of these operations, it's a bit like dipping your toe into the water of a beach and wondering if there's going to be a shark underneath that's going to bite you, because you just don't know how the patient is going to respond. So I'll go through some of the risk factors in a minute. Even if it's low risk, so if you have an elderly Caucasian person who's never had surgery before, or perhaps has just had cataract surgery, you would think that that was relatively low risk. But unfortunately, some of those patients can fail relatively quickly, and it's very hard to predict. So which aqueous bypass surgery should you do? I think it largely boils down to the one that you're comfortable with and that in your hands is relatively safe. And there's perhaps a couple of instances where you'd be careful about doing a trabeculectomy, for example. And they would be the very high myopes where there's a high incidence of choroidal effusions, macular problems, and also the patients with angle closure who have not had their lens removed. So you be very careful in those patients. So the high risk conditions for trabeculectomy failure, I've grouped them into three categories. So there are risk factors to do with the aqueous composition itself, risk factors to do with the tissue, the conjunctiva being primed to scar, and risk factors to do with cellular proliferation within the anterior chamber. And I think it's handy to try and group these together rather than having an extensive long list in your head. So aqueous sort of factors are important. So rubeosus iridis with all the growth factors that come out and cause the blood vessels to grow in the iris, that's what can damage a bleb. Vitreous loss or aphakia post intracapsular cataract surgery, the growth factors from the retina and the choroid can come straight through into the anterior chamber and cause problems for a trabeculectomy. Uveitis with the aqueous is abnormal, UGH syndrome with repeated hemorrhaging. In those primed for scarring, there's trauma, so where the patients had significant eye trauma before, past eye surgery, and we'll get onto this, and also uveitis, they're primed for scarring. And then cellular proliferation in the anterior chamber or anterior segment. The classic one is iridocorneal endothelial syndrome with metaplastic endothelial cells, but also very rarely one can have epithelial ingrowth from trauma or other causes. And there are other causes for high risk for failure as well, but they'll generally fall into one of these three categories. So talking about drainage surgery, and especially channel-producing surgery, the archetype operation is trabeculectomy, described in 1968, so a long time ago, getting towards 60 years ago. Now, one of the best long-term studies of trabeculectomy outcomes was this 20 to 25-year study in England, so in London, mainly Caucasian group. And this survival curve is really interesting. So you'll see that those who did best were those who had not had any previous surgery. Those who'd had a previous cataract operation, phaco or extracapsular cataract, did relatively badly with relatively high failure rates, 50% failure at about 5 years. Previous trabeculectomy also tended to do badly. The ones who did the worst were those who'd had vitreous loss or previous intracapsular cataract surgery. They did very badly. This table is worth looking at from the same study by John Landers and others. Those who were on previous medications, 2 or more medications, had much greater chance of failure, up to 16 times the rate of failure compared to those who had 0 or 1 medication. And we're seeing that nowadays with all of the newer agents like the prostaglandins, the alpha-2 agonists, carbonic anhydrase inhibitors. And then they quantified the relative risk of having had previous extracapsular cataract surgery, trabeculectomy, and then you'll see there's about up to a 100 times risk of failure if you had previous vitreous loss or intracapsular cataract extractions. That was in a Caucasian group in England, where the overall success rate at 1 year is 84%, probably a little bit higher actually. But when you look at studies from other Asian countries, Southeast Asia in particular, the survival rate is down to about 50% at between 2 and 3 years, so significantly worse. So all of those previous graphs would be significantly worse in a non-Caucasian racial group. The other thing about trabeculectomy is that when you've had a prior trabeculectomy, you're most likely to fail a second trabeculectomy. So that top left-hand graph shows that, with one kind of exception. If the first trabeculectomy lasted more than 5 years, then the chances of a second trabeculectomy working are relatively reasonable, given by that dotted line on the lower graph, which shows a survival out to 3 years of about 60 to 70%, which is not too bad. The tube versus trabeculectomy study in patients with previous failed trabeculectomies also showed that GDDs did much better, and we'll get onto that. But a major risk factor for trabeculectomy failure was those who'd had previous cataract extractions, shown in the red circle. So previous cataract surgery, for some reason, doesn't, these are uncomplicated cataract extractions, so no vitreous loss or capsule rupture. That adds a risk to failure, unfortunately, for trabeculectomy. Now, I'm going to digress a fraction. So 1976, so 8 years after Watson and Cairns described trabeculectomy, a plastic tube was developed for filtration as a way of potentially making trabeculectomy or drainage surgery safer. It's called the Kruppen valve, and it was basically a plastic tube, a bit like the pressure flow in its concept. Now, the success rates were not that great at just over a year, success rate of about 70%, having a pressure less than 24, which is quite a generous criterion. So they were popularized for a short time and then fell away in terms of popularity. Oh, sorry, something's happened to what's going on? Oh, here we go. Sorry. So in a sort of similar vein, the tubes that we use are transtrabecular tubes into the subconjunctival space, like a Zen or a pressure flow, may have roughly similar effects to each other in terms of pressure reduction, although the pressure flow might be slightly advantageous in the first couple of years. However, neither of them are as effective as a trabeculectomy in terms of overall pressure reduction and overall survival. So that right-hand curve, the left-hand curve is comparing pressure flow with Zen, and you can see the survival pretty much overlaps for 2 years. So they're probably roughly equal, but I think you have more bleb management with a Zen stent, but you've got other advantages. But on the right-hand side, this is comparing a Zen stent to a trabeculectomy being the dotted line and being the black line over 5 years. And you'll see that the trabeculectomy survives better. So are the Zens or the pressure flows safer or better than trabeculectomy? Well, maybe they're slightly safer in that you probably get less leak with a Zen stent, although arguably no less leak with a pressure flow because you're still having to cut and stitch conjunctiva. Conjunctiva is a little bit better preserved with a Zen stent, but the Zen stent and the pressure flow to some extent are less effective. And the pressure flow, because it's plastic, can probably induce endothelial cell loss over time. So I think you have to weigh things up, and certainly trabeculectomy will give you a lower pressure for longer than either of these procedures, and that's probably the most important factor. Now, coming back to the Kruppen valve, which is what I wanted to show you, that's that little plastic tube invented in 1976. What happened to it? Well, it fell out of favour, but the inventors then added a plate and turned it into what looks like a sort of flattened Molteno tube, and that was marketed in the 1990s. So the plastic tube morphed into a tube plus plate, which sort of leads me back to Molteno tube and glaucoma drainage devices in general. Tony Molteno first described his tube back in 1969, so 1 year after trabeculectomy. So this has been around for almost 60 years as well. So he did all the work in rabbits and then just did the human trials in South Africa. And that's led to a number of different glaucoma drainage devices, including our very own, the Werner GDD, which you can see here. And one of the advantages is that the plastic plate creates a permanent diffusional space, although the body does try to encapsulate that. And I've shown you this graph before, so I won't labour the point, but in terms of difficult high-risk patients, the GDDs definitely outperform a trabeculectomy. Now, you might say, let's do a GDD on everybody with glaucoma, but if you look at the cost analysis, a cost effectiveness analysis, you'll see that medications for those with mild glaucoma is still the cheapest way of treating glaucoma, generally speaking. And a trabeculectomy, which is the middle dot, is the next cheapest. And then you go up in cost if you implant a GDD. And the cost is not just financial cost, but it's also some of the risks of complications long term as well. So it's not a straightforward equation for if a patient has glaucoma, do a GDD. I think you have to consider the severity of the glaucoma, the likelihood of risk for failure before you embark on a particular surgical treatment. So in terms of summarizing, I've tried to cram a whole lot into just over 20 minutes. In terms of glaucoma surgery, nothing is really new, interestingly. So you can see that the basic principles of all these surgeries have been around for more than for 60 years. So basically our entire lifetimes for most of us. Now, angle closure is very common and especially should not be forgotten. And it needs a laser iridotomy or lens extraction to open the angle before you contemplate any form of drainage surgery. And lens extraction works very well, but obviously you don't do that in somebody without a cataract unless there's a very good reason. And it will cure about 95% of ciliary block. However, if ciliary block is present after a YAG laser iridotomy, then any sort of drainage surgery is high risk and likely to be complicated. Now, drainage or channel surgery, your trabeculectomy, or if you want to do a pressure flow or a Zen, it's basically the first time you're testing the conjunctival tissue reaction to aqueous humor. And you know that a group of patients are likely to fail, so those ones you'll take straight to a GDD, but most of the others you'll probably try a trabeculectomy. Now, trabeculectomy will require bleb management, which I won't go into, but so there's a lot of post-operative care to optimize the outcomes for the patients. And there is still a significant failure rate in spite of all of that optimization. Glaucoma drainage device surgery does give significantly greater success, but it comes at some greater cost. And all of that has to be borne in mind. And the MIGs, I don't think they're effective enough to be suitable in many cases, particularly those with more severe glaucoma, and particularly those with angle closure glaucoma, which is often more severe. And Werner, I think I should stop here. I've talked enough, and I hope that's helped to synthesize basic decision making for glaucoma surgery. Thanks very much.
Thank you for you your topic is actually quite a lot for glaucoma surgery, right? Okay, so I guess this is my turn to have my talk.
Yes, please. Thank you.
And
I'll
I
stop sharing.
think actually I bit overwhelmed, Prof, actually, because I think I have to cover a lot of a lot of cataract surgery. So I will try to make it simple, but I don't know whether I could make it simple or not. So
I'm sure, Werner, you'll do wonderfully well. And for those who don't know Werner, Werner is one of the senior glaucoma surgeons at RSCM Kirana at the University of Indonesia, and did an amazing PhD and is the inventor of the Werner GDD, which is a terrific device. Werner, thank you for speaking with us all tonight.
thank you, Prof. Okay, I will try to share. I'm sorry, share. Okay, okay, Prof. Hopefully, so hopefully I you could see my slide.
Yes, that's great. Thanks, Werner.
Thank you. Good evening, everyone. I will try to whether I don't know whether I could make it simple or not because we have a lot of cataract surgery cases in our hospital, and it is like a variety of cases from the simple one even to very difficult one. Yesterday I just do I think one of difficult cataract surgery as well. So so hopefully I will be able to share my experience and also share my knowledge with all of you. So, cataract and glaucoma, we know cataract is common finding in glaucoma patients, as we know that cataract is also an age or degenerative disease. And in term of pathogenesis, especially in our cases, we have like a lot of glaucoma patients with cataract in younger age, compare maybe with normal patients. So most of our case, especially in angle closer, we have like a younger patients for cataract surgery. And also we know that in secondary glaucoma, the time of cataract to come earlier is also, we have to know that, especially like uveitic glaucoma, in steroid-induced glaucoma, we know that I found that in patient with steroid-induced glaucoma, usually they also has earlier cataracts, like subcapsular cataracts. So we have to perform cataract surgery in those cases, even in neovascular glaucoma or in patient with post-surgery like post-vitrectomy or even post-trabeculectomy. We know that so glaucoma management itself will induce cataract earlier. So then we know that in glaucoma patients, cataract is quite common. So in cases with, if we want to manage cataract and glaucoma, we have to see several things. First, that we have to know what is the type of glaucoma that this patient has, because whether it is angle closer glaucoma or whether it is open angle glaucoma or whether it is secondary glaucoma, it will have spatial consideration. As we know that even in secondary glaucoma, there is one type like pseudoexfoliation glaucoma that we will know, or we will think that we have cases with zonular dehiscence. And then also we have to mention about the severity of glaucoma, because if we have a, oh yeah, they haven't tried to, okay. If it is, uh, if it is, uh, if it is mild glaucoma, we know that the patient condition, especially the nerve, is quite good, even in moderate. But if the case is actually advanced glaucoma, we have to be very considerate. Why? Because sometimes the fluctuation of the IOP will maybe make the condition even worsen. I have several cases of patient that actually after the cataract surgery, the patient feel that the eye is become a bit blurry. Although I know that the visual acuity become better, but in some part of his eyes maybe, or her eyes maybe, there is like because of the IOP in phaco IOL especially sometimes is very high, so it causes like a death of the ganglion cells. So it's maybe in some part there is there is a worsening maybe because of the ganglion cells death because of our manipulation during the surgery. So that's why the IOP is actually something that we have to consider. And then also we have to know the lens opacity, because the 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 mature the cataract, we know that it will be more difficult to overcome or to do the surgery. And then also we could see that sometimes we have to differentiate whether the decreasing of the visual acuity is actually due to the glaucoma or due to the lens opacity. If it is due to the glaucoma, even if we take out the cataract, maybe the visual acuity will be the same. So that's why we have to know the grading of the cataract and also the grading of the glaucoma when we consider to perform the cataract surgery. So we will not giving a false hope to the patient. As we know that now there is an evolution of cataract surgery. Previously, it is large incision, and now it become small incision, and actually it is good for the glaucoma patient. And previously, actually, there is like a maybe because of the large incision, and then also we open also the conjunctiva. So the conjunctiva is actually deteriorated if we do the like ECCE, because we know that there will be a fibrotic of the conjunctiva after we open the conjunctiva. But now, because we have like small incision cataract surgery, and also we have like a phacoemulsification, then we only do the incision in the cornea. So that's why the conjunctiva is still quite good. Uh, the the cataract surgery for the glaucoma patient mostly now is using a phacoemulsification, and then we know that uh, because of we are using the phacoemulsification, we have to know that there is probably IOP spikes within 24 hours after we do the cataract surgery, especially in patient with pigmentary glaucoma or pseudoexfoliation. There should be like a IOP spikes in these patients, even in other patients as well, because if we do cataract surgery and then when we didn't clean up quite good in the like viscoelastic materials, then probably it will increase the IOP in the first day or in the second day of after cataract surgery. So that's why we have to be very careful when we perform the cataract surgery in glaucoma patient. There is a descriptive study in our hospital on 2012 in whether the cataract surgery um, will influence the IOP. So in angle closer glaucoma, we know that in this descriptive study, the mean IOP decrease in a month, usually about 2 millimeter mercury, and decrease the medication about 70%. And then in open angle glaucoma, it's quite good. The IOPs decrease in a month about 3 millimeter mercury and decrease the medication about 55%. It is our descriptive study in our hospital. And what we have to do if we will have a cataract surgery in glaucoma patient, the important thing is we have to control the IOP prior to surgery, and even we have to use the hyperosmotic agent if it is needed. But if it is not, then we don't have to use that. So we know that for me, usually I will have like a limit of the IOPs about it below 25. I think it is quite safe to do the cataract surgery. If it is above 25, um, I have to consider many things. And even if I could see that if we can't control the IOP, even the IOP is very high, sometimes I will do the cataract surgery in general anesthesia. So the second one, we have to decide whether we will use the local or general anesthesia. General anesthesia is preferable if it is high risk in ocular condition or systemic ocular condition. So if the IOP, we can't control the IOP, then we will maybe choose the general anesthesia. But if we are able to control the IOP, we could do in the local anesthesia. And most of glaucoma patients actually is able to do in local anesthesia. Even in patient with angle closure, we could do that in local anesthesia. And we have to keep in mind that the large incision like ECCE or ICCE had a higher risk of choroidal effusion or even supraocular hemorrhage and even expulsive hemorrhage. So that's why I try not to do the ECCE or ICCE in patient with a high IOP. And if I have to do that, usually I will choose general anesthesia to prevent this complication. The choosing of phacoemulsification, because it is closed chamber, it is actually much safer compared to ECCE. And then the risk of like supraocular hemorrhage is actually very low in phacoemulsification. But I think I have one of case, but it is not supraocular hemorrhage, but actually malignant glaucoma occurred during the surgery. So we have to be very careful. And then also we have to do the gonioscopy to know whether this patient actually has a higher risk of ciliary block or malignant glaucoma. If we could see the ciliary body during the gonioscopy, then we have to be very careful because this patient maybe is prone to have malignant glaucoma. First, I want to talk about angle closure because I think the most difficult one is actually related with the angle closure. you have to know that in angle closure glaucoma, because of the acute attack, the pupil is actually like mid dilated, or sometimes the pupil will not move even we give the like adrenaline or something like that. So we know that the condition is the pupil is actually not quite good if it is post acute attack. And then also we know that there will be a shallow chamber. If the chamber is very shallow, then we have to be very careful not to harm the cornea. Because if we do the cataract surgery, and it is in angle closer especially, the chamber, because it is very shallow, the distance between the iris and then the cornea is actually quite near. So then we have to be very careful not to harm the cornea. That's why we have to like making a quite deep chamber, but also we can't make it too deep to prevent the very high IOP. In my case, usually I will try to maintain the IOP of the cataract surgery between the 40 to 50. So I hope that the condition of the patient eye is not too deteriorated during the cataract surgery. But recently, I just hear one of my colleague do the cataract surgery in the IOP of 30 millimeter mercury. I haven't done that yet, but he said that it is quite safe. So maybe later on I will try to use to do the cataract surgery on 30 millimeter mercury. But we will see later on. I haven't done that. I usually using the IOP between 40 to 50. And then the other thing is in angle closure, we have the corneal edema because it is usually related with the acute attack or post-acute attack. So sometimes the cornea condition itself, it is not quite good. So we have to be very careful. And then also there is a zonular dehiscence because the IOP, when there is an acute attack, the zonular dehiscence, the zonular will be affected, and then usually it will be less loosened, I think. So then, if we do the cataract surgery in patient post-acute attack, we have to be ready for the subluxated of the lens. So you have to be very careful when you do the cataract surgery because sometimes the zonular is actually not quite as good as a normal patient. And then the other thing is intraoperative. We know that sometimes there is a spike IOPS itself. If there is a subluxated lens or there is a zonular dehiscence, the BSS or the viscoelastic is able to moving to the posterior chamber, and then it will push forward, and then it will increase the IOP. So that's why sometimes in some patient, maybe sometimes when we do the cataract surgery, then abruptly the IOP increase. So we have to stop the surgery first and try to maintain the IOP, and then afterward we could forward. In cases like this, sometimes I have to perform the sclerostomy. I will show you the video later on. I do the sclerostomy in this patient and then try to take out the aqueous, the BSS that is actually going to the posterior chamber. So it will decrease the IOP. I will show you the video later on. And also the last one, we have to be very careful also with the choroidal effusion or hemorrhage. Because of the sudden drop of IOP and especially in large incisions such as ECCE or ICCE. But for phaco, it is quite likely. It is maybe it is like I haven't got choroidal effusion in phaco emulsification yet. This is the one for the atonic pupil. As you could see here, I will use the combination of silocaine one on one. So silocaine 1 and BSS 1 intracamerally, and then afterward I will give the adrenaline. So in my angle closure glaucoma patient, usually I didn't ask the nurse to do the mydriaticum drop prior to the surgery, but I will do that intrasurgery. Why? Because I could see that in some patients, when they, especially in angle closure, when they put the mydriaticum, then suddenly the IOPs increase. But if we using this strategy, actually, it is quite safe I have never have any patient in my cases during cataract surgery after I do this mix uh, compound with using the silocaine and also adrenaline intraoperatively. It is quite help. Why? Because adrenaline also work to make the iris diaphragma actually going to the posterior part. So it will open the pupil quite well. So the second one about the deepening the anterior chamber that I've mentioned previously, it is to prevent the endothelial touch. Also, it will give a space to do the phacoemulsification, and then also it will decrease the pressure to the capsular bag. And sometimes I will use the high density of viscoelastic to help to deepen the anterior chamber. If I can't deepen the anterior chamber using the viscoelastic because the lens is very big, like swollen, and then and the chamber is very shallow. Sometimes I will do the irrigation and aspiration of the cortex first prior doing other things. So after I do the CCC, I will do the irrigation and aspiration of the cortex to deepen the anterior chamber. Then I will do the next step after I could see that there is some part of the lens actually already decreased. Then I could see the anterior chamber is deepened. Then I will proceed with the next step. This is actually one of my case with angle closer glaucoma. As you could see that I usually do the silocaine subconjunctivally injection to adding up the anesthesia because most of my patients usually quite restless for the angle closer. So I know, so I give more, and then I will perform the incision in the cornea. And as you could see that I will give the silocaine and compound and also the adrenaline to open up the pupil like this. And then maybe the next will be mostly the same with all of you that I will do the CCC. Oh, sorry. I'm sorry, it's stopping. Okay, we will proceed here, Prof. The I think the computer is hectic. It is a bit stopping. Okay. I'm sorry. My computer is actually.
These things happen, unfortunately.
I will try to stop the.
Well,
Yeah, I know. Okay, I will show another. Maybe I will talk first, Prof. Prior. Uh, it is stopping. It can't. Okay. So I'm sorry. Uh, oh, my computer, Prof. Is protesting. I think it is protesting. I'm sorry. So maybe I will proceed with the next one. But actually, I have quite a lot of video here. So, hmm,
have you got the presentation up? We can't. We've lost the presentation as well.
yeah, yes, Prof. Because I actually try to. Sorry, Prof. Because I think my computer not.
Not behaving.
Yeah, not behaving. Not behaving. I'm sorry. I will try to. Okay. Sorry. I'm sorry for the problem. It's actually the problem is in my computer. It is not working.
Oh.
Uh, I try to move Prof uh with me I'm sorry. The this laptop doesn't work. Okay.
Well, you can tell us what your key points are.
Okay.
So I think you
So
were getting up to telling us about
yeah.
the heavy viscoelastic
Yeah, yeah.
and tricks to dilate the pupil as well, and
Yes, Prof.
handling the shallow anterior chamber.
Yeah. So actually, after the next one is actually the zonular dehiscence. I want to talk about the zonular dehiscence actually, because sometimes we have a patient with a zonular dehiscence in ankle closer. I will show the video if my computer behave, Prof. Later on. I'm sorry. So so if there is a zonular dehiscence, as we know that after the CCC, usually we could use the iris retractor to maintain, or maybe capsular tension ring is actually, we could use two things, whether it is iris retractor or capsular tension ring to maintain the to maintain or to balance the capsule. So then we could do the cataract surgery quite good. So sometimes even we could add up with capsule tension. I mean, we could insert capsule tension ring. I usually put that after some part of the nucleus had been taken out. But if the sorry. So sometimes if we are able to do the to put the capsule tension ring or the iris retractor, we could perform the cataract quite well. If I will show the video actually later on. And then the key point in zonular dehiscence is if we have a zonular dehiscence, we have to try to make the uh, the I mean the IOP and then also the phaco quite low. Usually I will use the low power and also low vacuum to make the chamber quite stabilized. But we have to know when we do the cataract surgery in case like this, we have to do that quite slow, because if we don't do that slowly, if we don't do it slowly, we will make like quite some a condition that actually make the IOP fluctuated if we didn't put the vacuum quite low and then also the pressure quite low. So that's why I usually make the condition of the phaco lower, to make the condition is a bit lower. Then if the IOP is able to maintain in safe, and then we could see that the chamber is stabilized, then we could perform the phacoemulsification quite well. I will show the video if I'm able to open the surgery. And then the third one, after the zonular dehiscence, also if we have a patient with mature cataract, we have to be very careful. Why? Because in mature cataract, usually the capsule quite what we call, sometimes if we don't do it slowly, there is like an Argentinian flag. So if we like puncture the capsule and make if we didn't do it carefully, it will like break out like a big break. So that's why we have to be very careful. We have to make sure that when we want to have like a CCC in a mature or hypermature cataract, we have to make it quite quite slowly. And then sometimes, usually, if I puncture the capsule, I will try to take out, like if there is a liquid, I try to make the liquid quite move out first. After that, after it is moved out a bit, and then I will put like a heavy viscoelastic, and then I will do the CCC slowly. I think my computer already behaved, Prof. I will try to open again. I'm sorry. So it is for the case with hypermature cataract. So in angle closure glaucoma, the key point is about the shallow chamber. I will try to open. Give me some time to open the Zoom first. I will try to. Okay. Okay. Prof, I will try to move again, Prof, with my um PowerPoint. So I will show the video. I don't think uh try to. Okay. I will show. Like this. So we could make it like this one, and then we could see that the iris is actually capable to help us to stabilize the cataract, the phacoemulsification we have. And now we proceed with when do we need cataract and glaucoma surgery. I think nowadays I usually try to make it like stepwise. So usually I will do it like cataract alone, and then I will do phaco usually. So how we make or discuss whether we have to um, do the cataract surgery or combine cataract and glaucoma, or just glaucoma surgery first then cataract. So it depends on the condition. If it is well controlled IOP, and it is like in mild to moderate condition of glaucoma, we could do cataract surgery alone. But for the advanced and there is a visual field damage, sometimes we have to perform with a combined procedure. It depends of the condition. If it is the IOP is borderline, the IOP is borderline, for the mild this and visual field damage, we could do the cataract surgery alone also, but also we could also do combined procedure. But if the condition borderline IOP and then the disc is actually moderate to advanced, we have to perform the combined procedure. But if the IOP is uncontrolled, usually we have to do the two-stage, mostly we do the two-stage procedure by doing the trap first and then do the cataract surgery later on. But if we urgent need to restore vision, so sometimes we have to perform the combined procedure as well. But usually if in uncontrolled IOP, I will do the in general anesthesia. There is a study by Clementine combining phacoemulsification versus combined phacotrap actually in cataract surgery. As we could see here, in the 3 months, the comparison between the phacotrap and the phaco is actually about 14 in the 3 months, 14 versus 17. But in 15 months, it is 13.2 combined with, versus 15.4. But in the 18 months, the phacotrap is about 13.6 and 15.9. So it's like about both, as we could see here, could maintain could control the IOP. But maybe for the phaco, it needs only more medication. And then for the postoperative complication, as we could see here, combined surgery is associated with more postoperative complication. Yeah, maybe because it is like a combined procedure. So that's why the condition or the inflammatory reaction will be more severe compared with only single procedure. But me, myself, if I could choose, I usually choose to do a two-step. I mean, like I will do the cataract surgery first, and then afterward I will do the glaucoma surgery. This is a phaco IOL in, I want to show you about the patient with angle closer in mature cataract. I haven't shown you the video. That's why, as you could see here, because it is like a mature cataract, and then also there is already quite synechia a bit, so I have to open up a bit the synechia, and we have to use uh, the blue to color up the capsule, and then perform the CCC carefully, like this one, very careful not to break the capsule in the wrong way, and then we have to perform the phaco carefully. Afterward, then we could finish it quite well. So in as you could see here, the pupil is not well dilated; it's only mid dilated. So that's why we have to be very careful to perform the phaco. And then also it is in angle closer glaucoma with control IOP. And as you know that usually the cataract, in my cases, the cataract is mostly is quite soft. So you have to be very careful in soft cataract. Don't use too power. The power it should be less. And also maybe you could a bit high the vacuum, but don't use the high power because it will break or sometimes it will touch the posterior capsule. So that's why in like this case, as you could see, the lens is actually not quite hazy, so it is quite even quite soft. So you have to be very careful. Sometimes even I cannot uh, do the chop, so I only do the cracking, and then after I could uh, divide into two part, then I will just do the I mean the phacoemulsification thoroughly using the removaling of the nucleus. So in cataract surgery in secondary glaucoma, as I mentioned to you, but maybe I only like making like a brief about this one because I don't think I have quite a lot of time um, to make a presentation about this. Like pseudoexfoliation, you have to be very careful with the zonal adhesions. For phacomorphic glaucoma, it is more or less it is like a primary angle closure. For lens particle glaucoma, and also for phacolytic glaucoma, like hypermature cataract, the one that the video that I have shown you, and then also for the steroid-induced glaucoma, traumatic glaucoma, and uveitic glaucoma, it is like we have quite a lot of thing to think of if we want to perform the cataract surgery in uveitic glaucoma or in traumatic glaucoma. So I think, Prof, I want the last one. Maybe I will show one of my video related with with uveitic glaucoma.
Mm.
There is one surgery I want to share with all of you. Actually, maybe it will be the last slide I will show. Sorry. Is my slide actually could be seen, Prof?
No, I can't see it, Verna.
The last one. I think it's only the last video I will
Oh,
show.
yes. Here we go.
Yeah.
Yes.
The one of a patient with combined, but it is quite long. I will move forward for the implant. It is actually combined phaco and implant in this patient. This patient has a light perception, visual acuity. You could see that the cataract here, it is like a seclusio of the pupil, and then I
Mm.
have to open up it a bit. But I'm quite lucky because this patient is actually still young, so about 30, 34 or 32 years old. So the patient didn't have the nucleus. So after I'm able to do the CCC, the nucleus is actually not very hard. So that's why I'm able to perform the cataract surgery quite well, and I could input the or I could put the IOL in this patient, and then in the last visit, the visual acuity of this patient is actually 6/12. So
That's amazing.
yeah, yes, bro. From light perception to 6/12, so it is quite good for the patient. But I have to perform the combined surgery in this patient because the IOP is not well controlled, and then the cataract is actually quite severe. So I have to perform both surgery in one setting. But as you know that if we do the combined cataract surgery and glaucoma surgery like this, we have to put more inflammatory medication, anti-inflammatory medication quite often. So usually I will put the like topical steroid hourly in the first day, and then also steroid orally in the first day until maybe at least a week. But it depends on the um, to put it maybe longer compared with a normal glaucoma. So I think it's my top, Prof. I'm sorry. I think I have quite talk quite long, about 40 minutes maybe. I'm sorry. So
No, Verna, thank you. Thanks very much for your
so
talk.
we'll proceed with discussion. We will proceed with the discussion. If is there any question from the attendee, uh, uh, we will open up for the discussion whether it is glaucoma surgery or cataract surgery. Uh, we will have a discussion.
There's some questions in the
Oh yeah,
chat.
oh yeah,
There-
from Sahar, Dr. Sahar, Prof.
There's one, the first one I can see. Good evening, good evening. Thank you.
Oh, the right location for posterior sclerostomy. Oh, this is my question, Prof. Actually, Prof, for me.
Is this I've got one here from Ariatika Alam. Thank you.
Ariati, Prof.
In angle closure
Oh yeah, yeah.
without significant cataract, shallow anterior chamber, is it wise to first do the iridotomy laser? Then if the IOP does not meet target, then we choose to do trabeculectomy. So I think the question is, in angle closure disease without cataract and without a shallow anterior chamber, is it first wise to do iridotomy? I think yes, because you've got a reasonably good chance of opening the angle. And if the angle is well opened, then it can be safe to do a trabeculectomy sometimes. But the main thing to watch for is ciliary block or evidence of ciliary block with volcano sign or ciliary processes. If you see that, then I think and the angle is closing again, then you have to remove the lens.
Sama juga gitu dan hanya
Oh, Verna, what do you think? Would you?
For iridotomy, Prof. Nowadays, if I could see patient with angle closure glaucoma, mm, but there is already a cataract, I usually choose the to take the cataract, Prof.
Yeah, but just this question was without any significant cataract. So when there's
Without.
when
Oh, okay.
no
Yeah, yeah,
cataract. Yeah,
yeah, yeah, yeah. I will usually do the I will usually do the LPI, Prof. If there is no significant cataract, Prof. So
yeah,
it is
yeah.
like, yeah, usually. But there is a question with trap, right, Prof? Because I didn't see the question here. I'm sorry. Maybe
Then
because I switched. Yeah,
there's there's
I
a
switched
part
to the display.
there's a part two. Is there any precaution to doing trabeculectomy after cataract surgery?
Okay.
And then when to consider GDD? I don't think there's any specific precautions. It's usually much safer. You Yeah, I mean, you would again assess the angle because occasionally you can get ciliary block continuing after cataract surgery in about 5%. I won't go into the causes of that, but it can happen. So you would still want to check the angle. If the angle is open, then it's generally safe to do a trabeculectomy. Um, But if the patient has got other risk factors for trabeculectomy failure, then you'd go straight for a GDD. That would be my sort of simple answer to that. Werner, do you want to add anything to that
Yeah,
question?
Prof. Yeah, I think it is the same, Prof. For chat after FACO, I think there is quite safe, right? So
Yeah.
yeah, we have to just to see the inflammatory reaction. Maybe because in Asia, Prof, I see that the inflammatory reaction in our patient is a bit maybe a bit severe compared with the Caucasian, right, Prof? So sometimes even if so the first day is actually one of the crucial thing. So usually if in the first day I could see like there is a like a severe vascularization or even like there is cells in the chamber, I will put more for a steroid topical or topical steroid. Even I will make it like every hourly or every 2 hours. So it will hopefully it will decrease the inflammation, and then we hope that the trap will be longer. The life of the trap will be longer.
Yeah, that's good. The next question, I think, is really for you, for Werner. You're probably better at handling this one. How to determine the right location for a posterior sclerostomy if we think there is balanced salt or BSS has gone into the posterior chamber during phaco. You know how sometimes when you irrigate, particularly during hydrodissection, I've seen that happen.
Yes,
Or at
Prof.
times there's a zonular weakness and some of the fluid goes behind and then the lens is pushed forward. So, Werner, what do you do in this circumstance?
I usually do like vitreous stepping, Prof, or maybe Dr. Sar mentioned it as a sclerostomy posterior, Prof, or posterior sclerostomy. And I will usually try to do that in the area of zonular dehiscence, Prof, because I know that the BSS will go through that zonular dehiscence. If we are able to notice the weakness of the zonal, then I will do the vitreous tapping or the posterior sclerostomy in that area. Usually about 4 millimeter from the limbus, Prof.
And what
And
size? You use a needle, like a 21 gauge needle, or what? How do you actually
no,
do it?
because I only want to take out the BSS or the aqueous from the posterior chamber, Prof. So I
Yeah,
usually only use the 30 or 26 needle.
26.
Yeah,
Yeah.
26 usually. It is quite safe because it is quite only small, needle. And then if the place is correct, usually we could take out maybe like about 0.2 or 0.1 cc of the BSS, which is coming into the posterior chamber, Prof. So after that, usually it will decrease the IOP, and then we could perform the cataract surgery quite smoothly after that.
Right. I think that's a very good tip. Thanks, Werner. Thanks very much.
You're welcome, Prof. Actually, I have the video also, but I don't think I could share that. Like, yeah, because of a lot of
We
zonal
might.
adhesion.
No, I think your description has been excellent. This question is from Fadima, and I'd like to ask, in cases of secondary glaucoma like neovascular or uveitis, how do you determine the best long-term surgical intervention? My answer to that is quite simple. Just do a GDD. Don't do any, well, as long as they don't have angle closure and ciliary block. I'm assuming you've checked on that. And of course, if neovascular angle closure looks different to ciliary block, but let's assume that there's no. So then I would do just go straight for a GDD. Don't even think about doing a trabeculectomy because that will fail. But the caveat with uveitis, some forms of uveitis that are mild and infrequent. So some of those HLA-B27, very mild uveitis, at least in Caucasians, or some herpetic uveitis, which is very infrequent, they might only be getting one episode every few years, then I will sometimes do a trabeculectomy and they can work quite well. But if it's chronic ongoing uveitis, then I'd go straight for a GDD. Werner, what would you do with your patients?
I think I will follow you, Prof. The same, Prof. For the vascular and UV, I think I usually put the GDD, Prof.
Yeah, yeah.
Mm.
This is another question from Vatian
Yeah.
Ramawati.
Mm.
Is it necessary to do cataract extraction as soon as possible in angle closure, or should we wait until the cataract is thicker? Werner, would you like to answer this one?
Okay. So if I have a cataract in a patient with angle closure glaucoma, I usually if there is a possible, I mean not visible cataract, and then also it we could see that it's actually closing the angle, because we could decide that using the gonioscopy. If we could see the uh, Mount Fiji condition, Prof. If we do the gonioscopy and we could see like there's like a mountain, so we know that the lens is quite swollen, I will do the cataract surgery. But if it is actually not like that, we still able to see the angle without like the picture of like Mount Fiji condition. I usually will do the LPI, Prof.
Yep, no, that sounds reasonable. So it depends upon your assessment of the degree of ciliary block or volcano sign, I think.
Yes, the volcanic sign.
The next question, I'd like to ask some questions. So this is from Hindun Zakia. When selecting intraocular lens for a glaucoma patient, how should factors such as disease progression, intraocular pressure, future surgeries influence the decision? My answer to that is to only ever use a monofocal lens in any glaucoma patient. Because my own view is that you don't know whether that patient will end up with severe glaucoma in 10 years' time or 20 years' time. And that if they have a multifocal lens and they've lost a lot of ganglion cells, their contrast vision will be much worse. So I think keep it simple. I actually refuse to put in any of those bifocal lenses. And if patients ask me and they've got glaucoma, I tell them to go and see another surgeon, because I know that they'll come back and complain in 10 years' time that they wish they'd had a monofocal lens. So I think for your own safety, your own sanity, if somebody's got glaucoma, just use a monofocal lens. But I'm old and I'm probably a dinosaur. Werner, what would you do? You're younger.
The same, Prof. The same. I also will refuse glaucoma patient to put the multifocal lens.
Yeah.
I will say to them, I only put monofocal for glaucoma patient.
Yeah.
The maybe I mean at the least only bifocal. Prof, the EDOF lens, Prof, the bifocal lens,
Oh, yeah.
the EDOF lens. It is
I don't-
only maybe the furthest one, not multifocal, but maybe that's the last option if they asking me to
That's
put the like bifocal
extending
lens. Maybe I
range. Right.
yeah, yeah,
Yeah.
but it's not actually not exactly like bifocal, right, Prof? Because it is like actually it is like the condition of the lens, the curvature of the lens, so it make like there is some kind of moderate focus part in the lens, but still mostly of my patients actually monofocal, Prof. Mostly of my patients,
Yeah.
maybe like about
No.
90% is monofocal.
Yeah. Right. So what best strategies to prevent IOP spikes or malignant glaucoma in glaucoma patients following phacoemulsification surgery? So the question is really following phaco surgery. So after phaco surgery, how do you prevent IOP spikes or malignant glaucoma? So usually malignant glaucoma after cataract surgery will become evident on the table, actually. It's usually when you remove the viscoelastic, the plastic lens then moves up towards hitting the cornea, and that's a bad sign. So my first, and what usually fixes it if you suture the ports, so get the Tenno nylon or Tenno Vicryl and just suture the ports very tightly and then reinflate the anterior chamber. And usually that fixes it. It's because there's a little bit of leakage, but once you've stopped that, and then if that fails, if the lens is still coming up, then you have to do a vitreal tap or a pars plana vitrectomy. But usually it'll happen at the table. Sometimes it happens days after, and then you end up using atropine. And so if you're really unlucky, you have to take them back to theatre and do a vitrectomy going through the iris. And so iridectomy, zonulectomy, peripheral capsulotomy with a core vitrectomy. Either you do it yourself or you ask a retinal colleague to do it. That's my own. And then preventing IOP spikes. It really hangs on removing the viscoelastic. So I put my irrigation cannula under the lens and actually flip the lens whilst I'm removing the viscoelastic. But I never put my aspiration cannula under the lens because you can suck in posterior capsule and create a hole. But using the irrigation cannula, put it under the lens, and then with the aspiration cannula, you can sort of seesaw the lens and basically suck out all the viscoelastic. But one of our hospitals, we use apriclonidine as well straight after surgery, which probably helps too. Sorry, Werner, what would you've probably got some other tricks that might help in this situation as well.
You're using bimanual, yes, Prof. Bimanual.
Yeah, that's right.
Bimanual.
Bimanual. That's
Oh,
right.
that's why.
Yeah.
Yeah, because in my hospital we don't have. I mean, usually I get not bimanual, but just one. So
yeah.
I just like maybe I will do like rock and roll, Prof. Rock and roll.
Yes, yes,
My teacher,
yeah.
like rock and roll. So I will like moving a bit the because I don't want to put the irrigation tip or aspiration tip below the IOL. So then I will like tap the IOL first under, and then make the fluid of the viscoelastic from below the IOL be go out. So yeah, it's like a rock and roll trick, Prof. Rock and roll
Yeah.
for to clean up the viscoelastic. Yeah, to clean up viscoelastic below the IOL. But
Right.
there is maybe one step if we have malignant glaucoma post phaco. I usually do like NDA capsulotomy, and then it will also break the hyaloid membrane as well. So usually prior doing the vitrectomy, I will try to do the NDA capsulotomy in patient post phaco, and usually it helps in most of the case. After I do the NDA capsulotomy in these cases with the also breaking the hyaloidotomy, the hyaloid membrane. Usually after that, the IOP will decrease. Usually, but if it is not, then maybe we'll proceed with the vitrectomy to help the patient for the malignant glaucoma. That's my answer, Prof.
I think that's a very good answer. It's a good point about the YAG laser capsulotomy and hyaloidectomy. We've got a few more questions, and I realise we've gone way over time. Shall we answer them quickly? Because I feel this
Yes, Prof.
Christy Magdalena, I'd like to ask, how do you usually adjust glaucoma medications following surgery? Depends on the pressure post-surgery. This is after cataract surgery. I always stop the prostaglandin because I'm worried about cystoid macular edema, and often my cataract patients don't need a prostaglandin afterwards, but that might be old-fashioned. Werner, have you got any other tips
The same,
about
Prof. Same.
the same? Okay,
The same, Prof.
Werner, this will be a question for you from Eric to join. I'm Eric from Indonesia. I'd like to, wants to ask my opinion on how to approach trabeculectomy in patients with possible bleb failure. What are the considerations? So I don't think you're asking about doing another trabeculectomy with possible bleb failure, although you might be. So if the patient had a well-functioning bleb and it's gone for 10 years, for example, or certainly more than 5 years, and then it fails, then you can consider a second trabeculectomy. But the problem is with a second trabeculectomy, then usually you've used up all of the superior conjunctival real estate, because each trabeculectomy takes up approximately 90 degrees of circumference, really. So you would want to be fairly sure that the previous trabeculectomy had worked very, very well, because often you'd be better off using a GDD. But I think your question might be to do with how do you manage bleb failure, which is a very long, we could do another whole session on that. I think the short answer is probably with 5-fluorouracil injections and needling, but then there's quite a lot in the technique. So I don't think I'd have to talk for half an hour to give you a very in-depth answer to that question, which is a very good question.
Maybe also the trick, maybe, Prof. The trick, if if we know that this patient is actually prone to have a bleb failure, maybe like that. If the
If
trick,
it
maybe
failed,
using a not
using
fail, but your trick in the trabeculectomy to prevent the bleb failure, because maybe it is the possibility that this patient will have a bleb failure. So what is the how to do the trap in a
to
patient with
avoid
possible
where
possible bleb
right.
failure?
I see. Well, I don't have any tricks in that. I try and do the best trabeculectomy on every patient. And I don't have any special tricks I mean, mitomycin C, I tend to use the same dose. It's 0.3 milligrams per mil. I don't think increasing that to 0.4 would make any difference. And I don't think
Is it,
increasing
Prof?
the time, no, I don't really think so.
Oh,
And
I see.
increasing the time, I think once you go beyond 3 minutes, I don't think it really makes much difference. Avoiding
Or
hemorrhage.
maybe the injection, Prof?
Sorry, sorry, Verna.
Giving earlier 5-FU injection. Giving earlier 5-FU injection. Is it
Yeah,
possible to
that
prevent
could
the bleb
help.
failure?
I think if you're giving mitomycin C, I think sometimes some patients bleed a lot. If it's possible to stop the
Oh, I
bleeding
see.
without too much diathermy, that helps the mitomycin C work better. But so if there's a lot of hemorrhage and you're putting mitomycin C into the area with the blood, then it's probably not going to work very well. That's
I
probably
see.
the only thing I can really think of. Yeah, it's a problem, basically.
Yeah.
Now, Werner, I think this is a question for you. In case of angle closure disease after acute attack with significant cataract and a pressure spike around 25-30, what's the better management? Is it better to do a TRAB before cataract surgery or cataract surgery first? And how long would you wait between the second surgery?
Okay, in post-acute, usually I'll choose cataract surgery, Prof. Especially if the IOP is between 25-30, because usually after I give the hyperosmotic agent, the IOP will decrease about maybe below 20 even. So then I will choose the cataract surgery. And even in my experience, after I do the cataract surgery, usually the IOP will be decreased. Like the one that I did yesterday. Oh no, a week ago, the patient actually has like about 40 millimeter mercury. After the mannitol, the IOP decreased to 20, and then I do the cataract surgery. Today, she came with IOP of 8, Prof. So,
That's very good.
yeah, so that's why I only do the cataract surgery for angle closer glaucoma. But then if I see that the IOP increase again, later on, maybe usually it will occur months, then I will perform the trap.
Just, yeah, do you combine your surgery with goniosynechiolysis at all sometimes within the
Oh,
setting of
yes,
closure?
yes. Yes. In some patient, I did that, especially if it is not, especially not in acute attack, Prof. Usually in patient with like Plato iris syndrome, Prof, like Plato iris. So with
Right,
the chronic glaucoma, a chronic angle closer glaucoma, silent chronic angle closer glaucoma, usually it has like a lot of PAS. Then I will do the goniosynochialysis. But for post-acute attack, usually after we did the phaco, it will open up the angle.
right. Thank you. And next question is a case of high myopia with progressive glaucoma. Which glaucoma surgery will be best for the patient? So that's first
Mm.
question. Yeah, that's a very good question. I think it's hard to give a sort of binary answer, but I tend to put in a GDD primarily in those patients because I think the chances of uh, very low pressure or hypotony are less with a GDD. It's a bit more controlled than a trabeculectomy. And so that's what I fear the most with a high myope is hypotony with maculopathy and bad choroidal effusions. But I think every surgeon might be a bit different. It depends how comfortable you are doing GDD surgery. Werner, what would you do? What's your sort of thoughts on very high myopes?
In high myopia, I still, I, s- I still picking up trap or GDD based on the IOP, Pro.
Yeah,
If
yeah,
I could, in a young patient with high IOP, usually I will put the GDD, but I never consider for high myopia. I haven't, I mean, if it is in high myopia and the IOP is not quite, I mean, I could control like between 20 to 30 millimeter mercury, I will just do the trap Pro. But
yeah.
I haven't seen like the one that you mentioned about the hypotony or maybe, yeah, maybe because of the patient condition is different, maybe.
Yeah, maybe that's something to do with Caucasians more. But yeah, I don't think there's a absolute rule there. But certainly to be, I worry about choroidal effusions. The next part of the question is, do we do prophylactic YAG PIs for primary angle closure suspects in routine cases? I think that's a complicated question. Again, we would have to have a session on angle closure. Depends upon the amount of angle that is in contact and whether there are synechii, I think in primary angle closure. I think by definition, primary angle closure suspect is somebody without synechii and has just got a positional contact. So perhaps if it's more than 180 degrees, I would tend to do it, or even more. Sometimes, depending upon where they live, if they live remotely, if there's any degree of angle contact, I would tend to do it. But I don't think there's a hard and fast answer there, unless there's a lot of contact. Werner, do you have a answer
I
there?
will do the I mean do the prophylactic if the other eye has we definitely has a glaucoma problem.
Yeah,
But
that's
if the
true.
both eyes PACS, I didn't do that. Especially if this patient didn't have any family history about of angle closer glaucoma. Because sometimes in our country, Prof, we have a lot of PACS without any like evidence of family history or even like probably previously like acute attack. So sometimes in our cases, PACS only will develop to become a glaucoma be only about 30%. I think it is the study in Singapore, I think. So that's why PACS, I mean the narrow angle. Sometimes I call it narrow angle to differentiate it between the patient with other eye with primary angle closer, and then the one is actually PACS. Then definitely I will do the PI, a prophylactic in PACS. But if it is the both eye PACS, I will like like considering whether this patient need the PI or not. Like the ZEP study, Prof. You know the
Yes.
ZEP study,
Yeah.
the
Yeah.
one that Dr. Tria presented previously.
Yeah.
So it depends if it is just SES in both eyes without any risk of developing glaucoma, or there is no family history, or even there no acute attack signs previously. I usually just observe the patient. But maybe it is different with Caucasian, right, Prof? Because angle closer is like seldom in Caucasian. So if you have PACS, you definitely will do the PI, right? Because it is
Oh,
very rare.
it depends on the degree of contact, how much
Okay.
circumference, basically. If it's more
Oh,
than, but we're probably a bit old-fashioned. I think the ZAP study was very interesting in that the risks of going on to primary angle closure glaucoma were fairly low, basically.
mm.
So, yeah. The next question is from Yulia
Julia.
Mitford.
Oh.
Your opinion in patients with uveitic glaucoma or glaucoma with iris, secondary glaucoma with iris bombay, that is where you plan to do a GDD implantation, do you do a peripheral iridectomy during the surgery? I think for any glaucoma surgery, you need to first cure or clear the angle closure. So if there's an angle, I think what you're saying here is that there's an angle closure component with the iris bombay. So that needs to really be fixed or addressed either at the time of surgery or before surgery. Because if you don't, you'll run into the high risk of ciliary block, malignant glaucoma.
Mm.
Uh, so I do some cases with combined lens extraction and GDD, and that they work quite well generally, I think. So now uveitic glaucoma with iris bombay were the same. I think you might mean iris, occlusio iris or peripheral synechia. That's slightly different. If the angle's open, then I don't think you have to remove the lens, but you might, and you don't even have to deal with the peripheral synechia either, as long as it's not secluded, not totally occluded. Werner, any comments there?
Yes, Prof. I think the same with you, Prof. So usually I will try to roll out the angle closer component first, and then if I have to, there are some cases, Prof. Maybe like small number, I combining GDD and iridectomy, Prof. Because the
Ah,
IOP is very high. And the IOP is very high, so uh, prior inserting the tube, I do the iridectomy, Prof, and then it deepening the angle, the deepening the chamber, and then I'll able to put the tube quite well. But it
right.
is only a small number because usually I will do the GDD after I correcting the angle closer component, Prof.
Yeah, yeah. This next part of the question is to do with synechiolisis. I think we've answered that already, so we might go on to, I'm just
Yeah.
conscious of time. Aprilla Elizabeth, I'd like to ask about zonular dehiscence during cataract surgery, how we manage the placement of the lens or using CTR. I think, Verna, you answered that in your talk.
Oh, I have the video, Prof. Yeah,
For
yeah,
the
I have
second
the video
question,
actually, but yeah, yeah.
for the second question in glaucoma surgery, when do we have to consider about low IOP cataract surgery? I think, Verna, you answered that in your talk to do with low flow and low pressure, but maybe you just want to make a comment um, for Aprilla. And she's our last question, actually. Thanks.
Low IOP, Prof. Low IOP cataract, ya, Prof.
Yeah, yeah, yeah.
And
I think
I
the
I
question is,
I never try the 30, Prof. I usually at least only 40, but yeah, maybe the setting should be lower, Prof. If we use the low IOP, Prof. Low IOP setting, and we have to be very careful because if we do the low IOP setting, it means the BSS high is actually very low, you know.
yeah,
So the if we are not careful in maintaining the chamber, then it will harm the cornea, and also it will harm the capsule, Prof. So
Mm.
then the settings should be low for the vacuum and also for the power. So that's why. And then also we have to be um, doing the phaco quite slowly, Prof. Otherwise, it will harm the eye.
Mm.
But I haven't used the 30 millimeter mercury, Prof. I still use the 40 millimeter mercury actually.
Yeah, I think I sit at about 40 millimeters of mercury too. Well, thank you. It's been a great session, great lot of questions, and we've run way over
Yes,
time. We're both guilty of running over time, but
yeah, I'm
thank you.
sorry, Prof.
No, 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 no. It's been great, and it's so good to see so many people come for the start of the symposia series. Should we have a photograph of us all, and then I'll have to head.
Yes, Tiara.
It's getting late in Perth, but it's wonderful to
Yeah.
see everyone.
Yes. Thank you very much, Prof. Thank you. Tiara, please do the. We will make a photo session.
Yeah,
Please,
thank you.
all of the attendees. Yeah, Prof. All the attendees, if you don't mind.
No, 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 that's great.
Okay, good evening, everyone. Thank you for joining today's lecture. I kindly ask everyone to turn on their cameras as we will be having a photo session.
Thank you for the question.
Okay, we will start the photo session. Please give us your best smiles. 1, 2, 3. Okay, next page. 1, 2, 3. Okay, that would be all. Back to Dr. Firna and Prof. Bill Morgan. Thank you.
Thank you. Thank you so much. Thank you, Dr. Nova. Thank you, everyone, for joining us today. Hopefully, we will meet again in the next session every month. Thank you. See you.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh.